Associate Director of Pharmacy. Just for the record again, my name is Dan McCool and I am the Associate Director of Pharmacy of MaineCare, and I have a fabulous team, and I see some of them are joining us today. This meeting is specifically around the rate determination for the pharmacy dispensing fee, and we're going to go through the methodology that MaineCare uses for the pharmacy dispensing fee. So just a couple of housekeeping items. I got to move my screens. Oh, there we go. Okay, so we're going to answer questions during the Q&A at the end of the presentation. And you certainly can put questions for the Q&A in the Zoom chat or raise your hands if you have questions during the Q&A time. And these presentations, these slides will be made available along with the recording on MaineCare's rate system reform page, which you can see there. Okay, so first thing is the rate determination process. So the Maine Law 22 MRS subsection 3173J, which is enacted in 2022, codifies these principles that we use for our rate determination. So it sets a schedule for regular rate reviews and adjustments. It assures the review of relevant state and national data to inform how rates and amounts are paid for various models. And it formalizes clear and transparent process for our rate determination, so publicly available. You can see exactly what we're doing. And then there's a MaineCare Advisory Committee, and their job is to ensure the program remains effective, efficient, and responsive to the needs of members or beneficiaries. And then there's also a technical advisory panel, and they advise on related technical matters as they seem appropriate, and then they review the annual schedules for rate determinations. Here's the process. So you can see we initiated the process looking at that sort of timeline or Gantt charts. We sent out surveys. There were some draft rates, and public comment is going to be taken, and then we'll finalize the rate. So going through the process step by step, the initiation notices were sent out on December 2nd of 2024. The Myers-Stauffer surveyed pharmacy providers from 12/4/24 through February 14th of 2025. We set a kickoff meeting and draft rate presentation, which is today. We'll be taking written public comments. They will be due by June 10th, 2026, so about a week and a half from now. And then the department will review those responses and respond to any comments, and then we'll do the rate finalization. Next, we'll talk about the overview of the pharmacy dispensing fee. So here's a visual, and I'm sorry, it's a little bit busy, but I'll break it down. So on the left-hand side, you'll see the way we reimburse for medication ingredients. So the formula is this. It's the lowest of one of these 6 or 7 categories: usual and customary, AWP minus 16.67 or 16%, FUL on the generics, Maine maximum allowable cost, WAC, the submitted ingredient cost, gross amount due, or NADAC, NADAC. That plus a pharmacy dispensing fee, which will give you the CMS definition of what that dispensing fee is. There are 2 components to that. Potentially, the pharmacy dispensing fee is $11.89, and there's also a rural dispensing fee adjustment which can be placed, and that can vary anywhere between 55 and 65 cents per prescription if the member lives in a CMS-defined rural zip code. And that is the total pharmacy payment. So medication ingredient cost based on those formulas plus a dispensing fee is the total pharmacy payment. Okay. Next we have, and sorry, I got to move some bars around, federal requirements to access the pharmacy reimbursement. So 42 CFR subsection 447.518 D1, MaineCare must do two things. This is a multi-pronged process. Consider both the ingredient cost and the professional dispensing reimbursement to ensure adequate total reimbursement to the provider. Must provide adequate cost-based data, such as state or national survey of retail pharmacy providers or other reliable cost-based data to support any changes. And then lastly, if changes are made, we must submit the state plan amendment or SPA to CMS for final approval. So there's oversight from the Fed. Here is the working definition of the professional dispensing fee per CMS. So the professional dispensing fee means the fee which, number one, is incurred at the point of sale or service and pays for the costs in excess of the ingredient cost of a covered outpatient drug each time a covered outpatient drug is dispensed. Two, includes only the pharmacy costs associated with ensuring that possession of the appropriate covered outpatient drug is transferred to a Medicaid beneficiary or member. Pharmacy costs include, but are not limited to, reasonable costs associated with a pharmacist's time in checking the computer for information about an individual's coverage, performing DUR and preferred drug list activities, measuring or mixing of the covered outpatient drug, filling the container, beneficiary counseling, physically providing the completed prescription to the member, delivery, special packaging, and overhead associated with maintaining the facility and equipment necessary to operate the pharmacy. And number three, does not include administrative costs incurred by the state in operation of the covered outpatient drug benefit, including system costs for interfacing with pharmacies. So we use the Meyer-Stauffer data from NESCO, which is the New England States Consortium System Organization, for the pharmacy dispensing fee cost data report. So how this works was pharmacies from 5 New England states were surveyed: Maine, Connecticut, New Hampshire, Rhode Island, and Vermont. Massachusetts was not included in the survey or did not participate. The survey instrument that was used was similar to previous surveys and developed in consultation with those 5 states. And the methodology was consistent with CMS guidelines. And we mentioned the collection dates that occurred between December 4th, 2024 and February 14th, 2025. And some pharmacies were excluded if they were closed, they changed ownership, or had less than 6 months of cost data based on their survey responses. Okay, so we'll get just a little bit into the weeds here. This is the response rate from the 489 pharmacies enrolled in MaineCare. We got an overall response rate of about 47%. So looking down the left-hand column, here are the categories of pharmacies that were looked at: chain and non-chain, and then urban, rural, and then out of state. So if you look down the total of eligible pharmacies, that was 483. And of those, the usable surveys were 227 with an overall response rate of 47%. So chain pharmacies response rate was 55%, non-chain was 29%. Urban pharmacies responded at 52%, in-state 47%, and out-of-state at 44%. Okay, and what we found with an N of 227, so that's all MaineCare pharmacies included here, using the median, and so there's a difference between mean and median. Mean is the actual average, which can be a little bit confusing, but median is a better way to look at an average because it eliminates any outlier. So let's just say one pharmacy had, I don't know, for example, a cost of $20 that doesn't really figure in or weight the whole group properly. So median is just a better statistical measure. So the median cost weighted for Medicaid prescription volume was $11.74. So we also looked at specialty versus non-specialty pharmacies. Pharmacies and a specialty pharmacy by definition is 25% or more of the prescription pharmacy sales or volume from IV, home infusion, blood factors, or other specialty services. So the number of specialty pharmacies were 52 and non-specialty pharmacies were 175. The dispensing fee for the specialty pharmacies, the median was $14.19. And for non-specialty pharmacies, the median was $11.52. So these are the definitions of chain versus non-chain pharmacies. A chain pharmacy is an organization, according to CMS, that owns or controls 4 or more pharmacies within the US. So a chain, the number of chains that responded were 157. The median dispensing fee was $11.27, and non-chain pharmacies, the median was $14.10. Also, we looked at the location. CMS gives actual designation to certain zip codes that were rural, urban. So you can see, for example, in-state urban, there are 64 of those with a median dispensing fee of $12.37. In-state rural was 72 and the median dispensing fee was $11.06. So looking down on the left-hand column, we see, so all in-state pharmacies, 136 of those, the median dispensing fee was $11.43. And then for all out-of-state pharmacies, and there were 39 of those, the median was $13.26. Okay, so also some findings on pharmacies by prescription volume. So there are 3 categories. 0 to prescription volume of 4,699. Their median was 1406 with median, the next group of pharmacies was 4,700 scripts to 10,999. The N of 50, the number was 59 of respondents. Their median dispensing fee was $13.88, and then 11,000 or more. The median dispensing fee was $10.53. So breaking this further down, annual total prescription volume. So between 0 and 43,999, the median dispensing fee was $15.86. Mid volume, 44,000 to 69,999, and there were 56 of those. Their median dispensing fee was $12.35. And then looking down at the last column, 70,000 and higher, there were 64 of those. Their median dispensing fee was $9.56. Okay, so Maine is proposing the following. We are proposing to keep the current rate of $11.89 per prescription. We are also looking at the rural dispensing fee, and we're making the recommendation to remove that extra rural incentive payment, which ranges between 55 and 65 cents per prescription for rural members, based on the fact that Maine's median is higher or average to other states. And Maine used a blended approach for the pharmacy dispensing fee. So there's no specialty dispensing fee, it's all one fee. And Maine picked a blended approach of $11.89. So we can't actually remove the rural dispensing fee until we do that 2-pronged approach. So I mentioned earlier in this presentation that we have to do 2 things. We're looking at the pharmacy dispensing fee today, which we are presenting this data to you. And then sometime in the spring, we will be looking at the methodology for payment for ingredient costs. Once we do that, we will make the recommendation after public comments, of course, to remove the rural dispensing fee. Okay, so here's the rationale. When we look at the states that participated, you can see the NESCO data by rate. So Maine is at $11.89. Vermont is $11.13, but they have a specialty drug category of $17.03. Connecticut is $10.75. New Hampshire, our neighboring state, at $10.47, and then Rhode Island, $8.96, but they have a long-term care facility payment per prescription of $7.90 for their dispensing fee. So breaking this down a little bit more, Maine's dispensing fee of $11.89 is above the weighted median cost of $11.74 that's been reported by these 5 states in their pharmacies. The NESCO report identifies the median as appropriate to consider costs. And most states, there's 32 of them, use a single statewide dispensing fee for all pharmacies. MaineCare's dispensing fee was the highest among NESCO states except Vermont's specialty drug rates. And then the rural dispensing fee does not effectively target rural providers. So there's a slight problem in the way that it is actually rolled out. So if the member lives, let's just say, in Aroostook County, and they go to Boston for treatment, and they get a prescription filled in a pharmacy in Boston, the pharmacy in Boston still gets the rural dispensing fee. So that's just a system limitation, but it is not necessarily an effective spend of state dollars and our tax dollars. And so the NESCO report shows lower costs for rural pharmacies other than urban pharmacies. So the costs are actually lower for dispensing fees. Okay, so I think we're going to open this up to questions and comments, and I'm going to need a little bit of guidance from Margaret, if you can just kind of help me manage any questions that come in from the crowd, and I'm happy to take those questions.
Matthew Marston has his hand raised if you'd like to speak.
Sure. Thank you, Matt.
Hey, good afternoon, Matt Marston. I'm the Chief Pharmacy Officer for Northern Light Health. Just a couple observations with this. I think, for one, I do have some concern about lowering dispense fee reimbursement at a time where the cost of medications has risen dramatically over what we see in typical inflation results, and labor cost has become an increasingly challenging element across healthcare in our state. So, I'm just cognizant of the impacts that this could potentially have, especially for those that have a much higher Medicaid payer mix than some of our more urban centers, with the removal of the rural dispense fee addition. The other thing I just want to mention too is we treat brand name medications and our ingredient cost reimbursement the same, whether it's just a branded drug or a specialty drug. This is inconsistent with our other payer contracts that we see in the commercial space, where specialty drugs have a separate carve-out reimbursement methodology. It is not uncommon when we dispense a specialty drug that can cost upwards of $30,000 a month at Northern Light for us to lose $1,500 to $2,000 when it's a Medicaid patient for every dispense. And we're a carve-out state, so there's no 340B discounts on those medications. So quite frankly, it can impede access to some of those therapies, because when we look at expanding into a different category of specialty drugs, if it's a high Medicaid mix, we would oftentimes be at a substantial loss in offering certain categories of medications like hepatitis C, HIV, or cystic fibrosis, which is another one where we have limited options in our state. So I wonder, aside from dispense fee, if we've looked at our reimbursement structure for specialty drugs at all, given the challenges that we're seeing there. So those are the two things. One, concern about the rural dispense fee elimination at a time where healthcare is struggling. And then two, the issue of specialty drugs being treated the same as regular brand name medications.
Yeah, so Maine is paying a dispensing fee. Thank you for the question. And Maine is paying a blended approach, a higher per average prescription dispense than our neighboring states, and the cost of doing business for rural pharmacies is actually less than city pharmacies. But Maine has a SMAC dispute process, so no one should be losing money on a prescription if the dispute process is used properly. So we encourage providers to use the SMAC distribution uh, process to make sure that they are getting reimbursed properly.
Sorry, one more question, if I may,
Sure.
too. When we're being compared to other states, I know Maine has a very high proportion of our state population covered by Medicaid. Is that being taken into account when we look at our other states that we're being compared to? Yeah, I know Maine, like a third of our population is covered by Medicaid, which is maybe higher than what we may see in some other states.
Yes, that data was considered as well, both nationally and for the 5 New England states that I gave that. But there are some states that also have high Medicaid percentage populations. Connecticut is one of them. New Hampshire has a pretty similar demographic to Maine. And so when you look at the data for Maine versus New Hampshire, we still compare favorably on what we're paying for the uh, prescription dispensing fee for MaineCare members.
If anyone has field questions, remember, feel free to either raise your hand or you can also paste them in the chat if you prefer.
So Margaret, if you see any that come into the chat, would you please alert me because I am not able to see the chat right now.
I will. Currently, we do not have any.
I'll give everyone a couple moments to regroup and see if there's any further questions. So we'll note Matt Marston's questions.
Matt, I was just going to put this in the chat, but maybe I'll just ask it. I know it's tangential, so I'll maybe we could have a side conversation about some of those medication concerns. I know we went over this with a long-acting injectable buprenorphine, and we're able to address that. And so, if there are other medications that are, you have that loss, then we certainly want to hear about it and address that. So, if you want to follow up on, please feel free to email Dan and I, and we're happy to go over those drug costs and see how we can be helpful.
Yeah, it sounds good. I mean, it's an area where we've gone through that process in the past a couple of years ago as we've evaluated different channels. I've not done it within recent months, but bridging a $1,500 or $2,000 per dispense gap, what we landed on at that point was there was just no way to bridge that gap with the current reimbursement methodology. So we opted to not expand into some of those categories for that reason, which creates access challenges.
Yeah, and I certainly want to hear about those. So
yeah, same.
We could set up a separate meeting. That'd be great. Thanks.
If no one else has any comments or questions at this point, Dan, could you just pull up the next slide that shows the comment information?
Yes. Sorry, don't get dizzy while I go through this. Next steps. Let's see. Okay, is this the piece that you were looking for?
Yes.
Okay, so next steps, the recommendations will get posted tomorrow for public review. And then there's a public comment period that's going to remain open for about 2 weeks, from May 27th to June 10th. Submit any email to ratereform.oms@maine.gov. All comments are going to be reviewed and summarized, and then we'll provide a consolidated document of the comments and responses. And then rate models will be reviewed and revised as the department deems appropriate. And thank you, Margaret, for helping collate some of this data and putting the PowerPoint presentation together. Much appreciated.
Thank you.
Well, if there's no further questions for the good of the order, I'm happy to help you redeem some time for this afternoon. Thank you, everyone, for your participation today.